Respected chairpersons, senior faculty, delegates, at the outset, I thank the Aster Ramesh Hospitals team for inviting me for this wonderful CME, and my special thanks to Dr. Vasanta. Both of us worked together in Visakhapatnam before she moved to this place, and I moved from Visakhapatnam to Hyderabad. So you have been listening a lot about obstetrics and the advances in obstetrics, how you are saving the lives of women, reducing the maternal mortality, and you also heard a lot about advances in the surgical aspects, the robotic surgery, the urogynecology, how you are trying to improve the quality of life. So I'm actually on a different ball game now. I'm going to talk about the other spectrum. So we have saved the lives of women with fertility related issues, birth and other things, but we need to save them by not getting cancers, because the lifespan of women is increasing, and with increasing age, we will all would be having the risk of getting cancers, not only gynecological cancers, many other cancers. So actually the recent statistics show that India is going to become a capital of cancers in addition to diabetes and hypertension. So that's why the government is focusing a lot on non-communicable disease, and in that cancer is also playing a major role. So I'm going to talk on preventive aspects, not about actually diagnosing the cancer and treating the cancer. We don't want any woman to get into the diagnosis of cancer, so we should aim to prevent it. And as obstetricians and gynecologists, all of us have a role to play in preventive aspects of gynecological cancers. So if you look into the figures, the global burden of gynecological cancers, it is quite significant and it's growing. They contribute almost 14.4% of newly diagnosed cancer cases in women with significant morbidity and mortality. If you come across the statistics of the year 2022, 1.47 million new cases were diagnosed and 680,000 deaths were recorded. This is with regards to gynecological cancers, not about other cancers. So if you come look into the Indian statistics, this is a study from Delhi. You all know that cervical cancer is the topmost cancer. Of course, if you include the breast cancer, that is the #1 cancer in women. Then after that, cervical cancer is the second most common cancer in women. But when you take into gynecological cancers, this is the #1 cancer. Then after that, as I said earlier, with increasing age and women living longer in the postmenopausal age, they are also subjected to endometrial cancer, ovarian cancer, then of course a small percentage of vulval vaginal cancers also we are seeing nowadays. So what exactly is the proactive protection? It's a wonderful statement, and actually when Dr. Vasanta asked me to talk on this, I really have done a lot of literature search to understand what is this proactive protection. It's an active healthcare approach focused on preventing cancer or detecting it at the earliest, most treatable stages. We all know that if you diagnose any cancer in a pre-invasive stage like in cervical cancer, or if you diagnose it in a very early stage like stage 1 or 2, we know that the lifespan would not be affected, and we can always aim for a cure in early stages or in pre-invasive stages. So that is what is the meaning of proactive protection. We don't want women to be diagnosed with when they come to us with the symptoms of the cancer. So this is called as a reactive approach. That means women come to you with symptoms, you examine, you take the history, and then you do the investigations and you diagnose that they have cancer. But many cancers are preventable by taking proactive measures against modifiable risk factors. So we know there are a few risk factors for each cancer. If you can modify those risk factors, you can reduce the risk of a woman getting cancers. So we all know that most of us are going for master health checkups. We are worried about hypertension, diabetes, and many other things. So similarly, we should also be worried about preventive aspects of cancers. I don't think any woman walks into us, at least in the present situation, asking for a pap smear test or a mammogram. But as obstetricians and gynecologists, as a part of our history taking, especially in gynecological cases, we need to ask them whether they heard about cancer screening, whether they had cancer screening anytime in their life. If not, we are going to do one now. So that is how we need to start our part of our history taking. That counseling also should be there. So what is this approach for this proactive protection? So vaccination, screening, lifestyle modification, genetic counseling, preventive or prophylactic treatments. So let us discuss about these things with regards to each of the gynecological cancers. So cervical cancer, we know already that it is the commonest cancer in women in India. Almost every year, more than 130,000 women would be diagnosed as new cases, and more than 70,000 die within 1 year because they're all diagnosed in advanced stages of stage 3 and stage 4. But we know that this is a preventable cancer. This is caused by high-risk HPV infection. Those women who have got persistence of HPV infection in their genital system are at risk of getting cervical cancer. And we know now that it can be prevented by vaccination, and it can be taken care by organized population-based screening. I think all of you must have heard about these global targets declared by World Health Organization. And this is the director of the WHO. 1 woman dies of cervical cancer every 2 minutes. Each one is a tragedy, and we can prevent it. How do we prevent it? Through cost-effective, evidence-based interventions, including HPV vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancers. We can eliminate cervical cancer as a public health problem and make it as a disease of the past. So that is the statement which was made in the declaration came in 2020, and we are supposed to reach these global targets by the year 2030. So you must have heard this mantra of 90%, 70%, 90%. So 90% of girls have to be vaccinated by the time they reach the age of 15, and 70% of women, eligible women between 30 and 65, at least twice in their lifetime, 35 and 45, they need to have a screening by a high precision test. The high precision test is considered to be the human papilloma virus screening test. And similarly, it doesn't end there. Once they are screened positive, you need to triage further, you need to do colposcopy and offer the treatments. So that is the 90%. So if you remember this slide, this is a wonderful slide which tells you everything in one step, how we are going to eliminate cervical cancer. So as I said, the primary prevention is by HPV vaccination, and after that, as a secondary, you do the screening, you have the VR test, you have the cytology, you have the HPV test, and after that, you can do a colposcopy and I take a biopsy, and based upon the biopsy report, you can offer the treatment. So this is the road for cervical cancer prevention. So just we all know about the risk factors for cervical cancer. We know that multiple sexual partners, early marriage, early sexual activity, multiparity, and all these things. And now it is proven beyond doubt that HPV virus is the responsible agent, and all other factors are the cofactors. So if you see this picture, you will understand how HPV causes pre-invasive cancer and which can progress into invasive cancer. So here, this is the normal cervical epithelium which can be affected by HPV virus once we start the sexual activity. So our aim is to vaccinate the girls before they start their sexual debut so that they will not get this infection of HPV into their genital system. So by chance, those who could not receive the vaccine because of the vaccine is there only for the last 15 years. So the next step would be doing the screening. So in screening, we can test using the different modalities, what I have said, and this virus slowly enters into the cervical cells. And again, if you have a good immunity, more than 90% would clear the infection. But those who are immunocompromised, the infection can persist, and that can produce a lot of changes in the cells, and finally it becomes a pre-invasive to invasive cancer. But this doesn't happen overnight. It takes almost 10 to 15 years. So you have a long window period of screening your woman for these cancers. So that's why we said the screening tests are to be offered for women between 30 and 65 years of age. So these are the vaccine recommendations which are there in our FOXY website. So this is the FOXY recommendations. We do have our Indian vaccine that is called Sarvavac, which is made by Serum Institute of India. We have imported vaccines, Gardasil 4 and Gardasil 9. One is quadrivalent, one is nanovalent. So we can use all these vaccines according to the age schedules that are recommended by the government of India, and we can vaccinate all our girls. Then we can even vaccinate the boys with our Indian vaccine. You may be asking why boys. Boys are also at risk of getting penile cancers, and both men and women are at risk of getting anal cancers, oropharyngeal cancers. In addition, women can be protected not only with the cervical cancer, but vulval and vaginal cancers. By one vaccine can protect 6 cancers. So timely vaccination is one of the preventive aspects, proactive preventive aspects. And of course, the screening test, you are all know about the screening test. Visual inspection with acetic acid and leucoalzidine is what is recommended by our government of India. And cytologic screening tests are very popular. The pap smears, either conventional or liquid-based cytology. Most of the government institutions do have the facilities to do it. But the latest WHO recommendation is to move towards HPV screening. And of course, we don't have a government recommendation. We don't have India-made HPV tests. We have imported tests which are validated. But in good centers where the facilities are there, resources are there, at least in private setups, many people are doing primary HPV DNA testing, which is considered to be the gold standard because of its high sensitivity and high negative predictive value. And these are the screening recommendations according to the age. In a good resource settings, if you want to screen, you can start from 21. But in India, the recommendation is from 30 years of age. And of course, immunocompromised, you can start from the age of 25. So before 30, never do a HPV screening test because majority of women will be HPV positive, and unnecessarily you will be over investigating them. So you need to do HPV testing only after the age of 30 for general population. Only in HIV and immunocompromised you can do from the age of 25. So the screening interval varies depending upon the test you use. Then that is all a little about cervical cancer. There's a lot to talk to. So I just stop with this vaccination and screening. Coming to the endometrial cancer, the lifetime risk of endometrial cancer is 3.1% and the overall 5-year survival rate is 81%. In India, it accounts for 4.3 per 100,000 women. The incidence is increasing because of the lifestyle changes and metabolic syndrome of hypertension, diabetes, obesity. So these are some of the risk factors for endometrial cancer. Some of the factors are modifiable, some of them are not modifiable. The modifiable risk factors are, as much as possible, we are not using estrogen alone treatments. We are always giving a combined estrogen progesterone preparations. And sometimes women on tamoxifen for breast cancer, anti-estrogen, are slightly at an increased risk. Then nulliparity, obesity, metabolic syndrome, as I said earlier, sedentary lifestyle, consumption of red meat, alcohol, and fatty foods. These are all the modifiable risk factors which are in our hands, but we can't modify increasing age, early menarche, late menopause, PCOS, estrogen-producing tumors, type 1 diabetes, Lynch syndrome, Coverdin syndrome. These things, the genetic things we cannot modify, but at least we can do some kind of a screening in women who are at a higher risk for getting endometrial cancer. So this slide which shows us about healthy lifestyle, we all know we have been discussing about healthy lifestyle from morning to reduce many other conditions, not only cancer. So the screening for endometrial cancer is not recommended for general population, but those who are at high risk, like what I have said, shown in the picture, those women need to have screening. They can have a transvaginal ultrasound annually, and if needed, if they have any suspicion, then they can go for endometrial sampling. But as such, any woman perimenopausal, postmenopausal comes with any menstrual irregularities, and for that matter, postmenopausal women coming even with one episode of bleeding, it's better to investigate. So we do usually transvaginal scan to find out the endometrial thickness, and if the cutoff is more than what is recommended, we all do endometrial biopsies or hysteroscopy or whatever it is. And that actually helps us to diagnose endometrial cancer in very early stage, and the surgery is the gold standard for early stage endometrial cancer. And that actually gives a very long, good survival, good response, and almost cure for many women. Then coming to ovarian cancer, I know it is the most dreaded cancer, and we cannot really diagnose an ovarian cancer in very, very early stages. And we don't have any screening tests for ovarian cancer for general population. So patient characteristics wise, advanced age, personal history of breast cancer, these are all high risk factors. So if there is a strong family history of ovarian cancers, or those women who had ovarian cancers or breast cancers are genetic testing positive, that is BRCA1 and BRCA2 mutations positive. So in those situations, the entire family is at a risk of getting these cancers. And similar to endometrial cancer, nulliparity, early menarche, late menopause, where there is more and more chance of continuous ovulation, which actually acts as a stimulus for ovarian cancer. So PCO, infertility, endometriosis, ovulation induction, these are all the risk factors. So what we need to do is, for general population, as I said, we don't have any recommendations, but all high risk women have to be on a follow-up at regular intervals. They need to have a physical examination, regular ultrasound scan, and CA125 estimations. Of course, there are lots of ultrasound indices are there, Roma, so many things are there. But whenever you see any cyst, it has to be characterized according to IOTA guidelines to see whether it is benign, malignant, or suspicious. Suppose somebody is a genetic testing positive, then we need to think of some prophylactic measures for them. So these are some of the recent advances. There are lots of advancements are happening for ovarian cancer screening. So a lot of biochemical tests, blood tests to identify the biochemical markers, circulating tumor biomarkers. These are all not into clinical practice. These are all in the process of evaluation in clinical trials. So just one word about genetic testing, because so many things are coming with one sample of blood, one can detect so many genes which are at risk of cancer. So like that, we are seeing lots of ads and other things. But for any test, for any genetic test, one should have a good pre-test counseling. First of all, we need to understand what is the importance of this genetic testing. Suppose if the test comes positive, what are we going to do? So that is very, very important. And especially, as I said, if there is a strong family history of a genetic abnormality like BRCA1, BRCA2, or microsatellite instability, Lynch syndrome, and other things, then only those families need to be screened. And then, of course, the process of sample collection, laboratory analysis, results, and post-test counseling, all these things have to be done by a proper person, the genetic counselor, and those who are experienced and those who have enough knowledge about these tests. It's not just a simple testing, similar to what we do for our anomaly scans and other things, NT scans, so many things we are doing. So we all need to learn about these aspects very clearly before you advise anybody for genetic testing. Then just one slide, this is the last slide. So if you have done all these preventive strategies, if you find somebody as a high risk group, you can do frequent screenings, especially those who have got a strong family history of breast cancers or gene positive breast cancers. You can advise them mammograms and colonoscopies for these colon cancers and other things. Risk reducing medications. So OCPs also can protect against ovarian cancer and endometrial cancers. Then of course anti-estrogens also have a little role to play for women who have got a higher risk of breast cancers. Then we all do a lot of salpingectomies when we do hysterectomies because to reduce the incidence of ovarian cancer, especially the serous cancer, and we know that the fallopian tube is the precursor for ovarian cancer. So especially in high-risk women, just doing a salpingectomy doesn't serve the purpose. You need to do risk-reducing salpingo-oophorectomy. And of course, there are situations some women do undergo prophylactic mastectomy. So lifestyle changes, no excuse for that. So the best approach is a personalized plan developed with a healthcare provider, tailored to the specific genetic mutations, cancer risk, and evidence for such interventions. So thank you very much for the opportunity given to me.